Welcome to another webinar. This webinar is on macular degeneration. With macular degeneration, there's a lot that goes into it, so I think we should probably put a little disclaimer that the advice from this webinar is general in nature and that you should consult with your doctor, your ophthalmologist, or your optometrist when it comes to your specific situation. And no doubt all of those people will be involved with your care. So with that said, let's move into the webinar. So of course the key for this is that we have a better understanding of what macular degeneration or AMD is. It's the leading cause of vision loss among adults 50 and over, and we'll talk about how it's treated, and in the case currently there's not much to do when it comes to treating, and that's often at the end stages. And then so as us as individuals, what do we do about it? And most of that comes down to living a healthy life, which I'm sure is a pretty loaded term. So it's in a condition that affects the central part of our retina, which is the macula, and especially more specifically when it's the very middle, the fovea, where all our fine detail vision is, where the concentration of our light reacting cells, our photoreceptors, are at the highest concentration. If we start losing those or we damage those, it's like taking a high pixel camera and knocking out some of those pixels and not being able to see so well, having a blurry image. So as it says there, commonly causes blurry or loss of central vision. And of course that would lead to a big impact on life. Once again, driving, but also things like reading, recognizing faces, watching TV, seeing the sport, playing golf, playing cards, anything like that, writing, music. Yeah, it's not good at all. Anybody who knows somebody with macular degeneration will understand how much of an impact it can have on their life. Which brings us to our first point, family history. If the parent has AMD, then you have a 6 times increase risk, and if a sibling has AMD, then you have a 5 times increase at risk. So like many things in health, knowing your family history is pretty important. There is a book by Dr. Peter Attia called Outlive, and one of those, and the main point of that book is understanding the 4 horsemen, which is cancer, heart attacks, dementia or Alzheimer's, and stroke. And that's usually what gets us. And when it comes to vision, as we said, if you're going to go blind, for most people over 50, it is macular degeneration, and it's quite heritable. And again, this goes back to what I started off with, that your medical history matters when it comes to macular degeneration, and you should take into context what your doctor says and what your ophthalmologist says and what your optometrist says. So, as we said, there is end-stage treatment. How do we stop ourselves getting down the road of macular degeneration? So, in this Facebook Live, when it's still live on our page, I'll link to a very good video that comes from 2017. Or if you're watching this later on YouTube or in the podcast, if you check out the show notes, I'll have a link to this video by Dr. Devinder Chauhan. He is a Melbourne retinal specialist, and he had a wonderful talk from Low Carb Down Under back in 2017. Being an Australian ophthalmologist, he termed it fish, green and gold. And these are the beneficial foods: oily fish, green leafy vegetables, and just really extend that out to vegetables. I think, there's a yellow capsicum in that photo. That is the highest concentration of lutein and zeaxanthin. Nuts and eggs. And I'll stipulate there with nuts, they should be raw nuts. Because when we come down to our second point, not the staying active side of things, the avoid processed seed oils. Of course, if you roast nuts and they sit on a shelf for a long period of time, those fats that are in the nuts denature, and that appears to be an increased risk. Staying active boosts the circulation to the retina, the layer that's affected in macular degeneration, the pigmented epithelium, is surrounded by a massive vascular network. Talking with the students lately, our lecturer at Auckland University is Spanish, and it was always hard to hear or understand when she'd say coriocapilares. It's hard enough to say in an English accent without a bit of Spanish going on there. But anywho, I digress. Staying active means that you get increased blood flow around that retina, and that helps to remove the buildup of waste products that happen in macular degeneration. And so these habits can reduce your risk, and Dr. Devinder basically says you can eliminate those increased odds that you get from a family history. Now, AREDS 2 formulation for immediate and advanced disease. And this is where this directional information comes from. I've done a couple of videos and blogs over the years, and written a couple of articles for our optometry publication, Australasian one, which is My Vision. And I've talked about the AREDS 2 study. Joe Rogan annoys me. I'm sure everybody has something about their profession that Joe Rogan gets wrong, and I hope he's wrong with this one. His best friend is an ophthalmologist, so I hope he's wrong in that he says he has macular degeneration and that's responsible for him not being able to read anymore. But I think he's just got plain old presbyopia, a lack of flexibility of his lens. However, I guess it's malinformation what Joe's saying, although I don't think he's doing any harm by suggesting people take the AREDS 2 formulation. It's got lutein, zeaxanthin and zinc in it, and what AREDS stands for is the Age-Related Eye Disease Study, and the reason why they had to do it twice is when they first started, they used, you can see the carrots there, they used beta-carotene. And unfortunately, beta-carotene increased the risk of lung cancer for smokers. And when we get to our next slide, we'll see, like many things, smoking increases the risk of macular degeneration. So having a supplement that is to reduce the risk of advancing macular degeneration is no good if you kill the patient due to lung cancer. So the second study, they went a bit more specific with the vitamin, and they narrowed that down to lutein and zeaxanthin. The 5-year review showed that that was protective for intermediate and advanced disease, progressing in about 33% of people, and good news, it didn't increase the risk of lung cancer. And last year they released their 10-year information, and that supplement was still providing about a 27% reduction in the risk of causing vision loss for that intermediate and advanced disease, and still did not cause an increased risk of lung cancer for smokers. So that's wonderful news, and they've got it right, and that's what we have on the shelf at Ashburton Eye Care, is the AREDS 2 formulation by clinicians at the recommendation of Dr. Sean Every, who many of our patients will see, and other people's patients will see in Ashburton, often about once a month at Ashburton Eye Care. So yeah, that's one of the big things there, is what we eat, and also how we interact. As I said at the start, staying healthy, which is a loaded term. Staying active, if you're watching our Instagram, I talked about how having over 10,000 steps a day reduces your risk for glaucoma due to blood vessel flow to the optic nerve. It's a bit like this for the macula. Increasing that blood vessel flow around the retina helps to get away antioxidants, free radicals, and provides support to the retina. So makes sense directionally. And here we go. Smoking, of course, quadruples the risk of macular degeneration. We probably all knew that. But here's one for the current smokers to have a bit of a pat me on the back for breaking that habit. 10 years smoke-free reduces the risk levels to a non-smoker. So yeah, bit of purchase there for giving up the cigarettes. It's always a good talking point when people are smokers, is letting them know that if they manage to stay smoke-free for the next 10 years, they reduce that risk of macular degeneration. So yeah, key point there is these habits can reduce your risk. Alright, so how do we monitor it? We saw in the glaucoma webinar last month, or just over a month ago, that we use the OCT in our practice quite on everybody, and that is on everybody, whether that's just a central scan to look at the nerve and the macula more broadly, or more specifically when it comes to glaucoma, measuring this top layer here, which is the ganglion cells, and then off, get back one, off when it goes off to the nerve, the retinal fiber thickness, or here at the macula, making sure that it looks like A. If it looks like B, having a bit of a discussion that there are some little build-ups underneath. This is early. If it looks like C, then we might want to think about taking that AREDS 2 supplement. If it looks like D, coming up with some solutions for probably low vision, because we've got dry AMD here, this big window defect. You can see all the light being let through. That's because we've lost the pigmented layer through here. And we'll get on to a little bit about D towards the end here, with some exciting things from another ophthalmologist from Southern Eye Specialist, Jim Borthwick, and the work he's doing here in New Zealand. E, again, we might send you to Jim or Sean or the eye department to have some Avastin, which was that next slide we looked at. Or F, again, probably Avastin, and yeah, that's hard work when it gets to F. But this webinar is about A and B, maybe C, and of course wondering what to do here. That brings us to anti-VEGF, or Avastin, or Eylea, which, when you see that picture, is quite a daunting prospect. The ophthalmologist, or sometimes their nurses, will inject what's called anti-vessel growth factor, anti-VEGF, into the retina, and that will diffuse into the blood supply in the retina, and it'll resolve away, if we go back, resolve away fluid within the retina, and any vascular membranes that are under here will hopefully resolve away and stop leaking. So you hear the term wet macular degeneration. Wet is when there is fluid and blood in the retina, and that's disrupting the vision. Jim was saying the other week that dry is not wet, but dry is not necessarily good. And that, as I said, I was hearing Jim talk 2 weeks ago, and he was talking about what they're now trying to do for dry macular degeneration. So some of it does involve injections, now not always within the back of the eye, and another one is subcutaneously, and they are looking at ways in which they can stop dry macular degeneration from proceeding. So with dry macular degeneration, if we go back again, we've lost the pigmented layer and then the retina above it, and so if this is away from the fovea, which it often is, it leaves the fovea behind to the end for some reason, and it's just here on the side. We want to stop that there. We don't want it progressing across. So some of these new treatments, some of which are gene therapies, are stopping that progress of the RPE, and that's to do with the inflammatory pathway that they think is going on at the macular area, and that's probably brings me to something that I've had a long conversation with Grant Schofield about at AUT. He's the Professor of Public Health up there. As I said, I wrote some articles for our My Vision, and there is a concept, and this is a difficult one, and as I said at the start, needs to be dealt with doctors and probably nutritionists or dietitians, and that's the idea of fasting. Now, we want to preserve muscle mass in our elderly, and unfortunately macular degeneration affects elderly people, but what fasting appears to work on is it lowers the complement factor, which is a step along our inflammatory pathway, and gets rid of waste material. That's a thing called autophagy, if you've ever looked at fasting. But the problem, of course, is that we don't want to lose muscle mass. So there are, I know we're not rats here, 3 rat models of macular degeneration, and they've done some studies on them, and 2 of those rat models showed a benefit to fasting in the rats. And of course, fasting in rats is a bit different to fasting in humans, but directionally accurate. There was another model that it didn't work, so that's kind of like, In a more general population base, they looked at some people with macular degeneration in Japan, and they found that those that skipped breakfast had less macular degeneration advancement than those that had 3 meals a day. So it's not very scientific, but it is interesting. And so there is a couple of models. Again, Grant comes in here. Their book, What the Fast, looked at doing what are called super fasts on a Monday and Tuesday, where you would have a highly nutritious dinner that is low in carbohydrate. You'd eat low carbohydrate through the week. So again, trying to reduce the inflammatory load, and then on the weekends you'd relax a bit more. Of course, like anything, you should be doing resistance training and aerobic training, trying to be active, as we said at the start. So in the context of that, that may be something that would work. And Grant and I have had a discussion that it would be worthy of a master's project if I could collect some data on would people listen to an optometrist in terms of nutrition. So if you wanted to give some feedback, I'll be interested in your feedback on that point, because obviously doing a master's is no mean feat, especially when you've just taken over an optometry practice. So that's one that I've had on the back burner for a number of years, and again, it's probably still on the back burner for now. But yeah, if you've got any thoughts on that one, I'd love your feedback. And yeah, it was just interesting to hear Jim Borthwick talk about these new medications for dry macular degeneration influencing the complement pathway. On the flip side, like I said, there's gene therapy that they're looking at. They're looking at trying to boost what's called mitochondrial function, so the batteries within our cells. Once again, fasting is supposed to boost the mitochondria, and that gene therapy comes from of course, the COVID vaccine. But interestingly, with COVID, they saw more advancements of macular degeneration, and again, that was around this complement pathway. So whilst there's been lots of complexities out of COVID-19, we are seeing some of the benefits of things we have learned from that big disruption to the system. So hopefully that mention of COVID-19 doesn't get this webinar flagged or anything like that. But yeah, that's where our scientific knowledge and things cross over is quite beautiful. And again, when you've seen things directionally before, like I said, fasting and these rat models and these population studies that they did in Japan having a little bit of effect, and the possible mode of action being boosts in mitochondria or downregulation of this complement pathway, it's interesting to see that the science is also exploring that in different ways. And yes, so back to Jim. If you have dry macular degeneration, your optometrist can refer your case to Southern Eye Specialists. They can have a look at that. They can look at the enrollment criteria for one of the 3 studies they've got, and you could be part of that study. Of course, there's the chance that you're in the sham profile, but Jim reassures us that that's 1 in 3, so your odds are reasonably good for having or being part of the experiment, and hopefully reducing the progression of dry macular degeneration. And no doubt towards the end of that there'll be a crossover arm if that has been shown to have an effect. So interesting stuff when it comes to dry macular degeneration. There's always gene therapies in the background. I was reading an article today that was talking about gene therapies for macular degeneration. People are always talking about the possibilities of retinal transplants, and then there's the bionic eye out there. Yes, that is a real thing, not just Terminator, although at this stage it's just being able to receive light messages at this point in time. But yeah, we shall see what happens with science and AI and all that sort of stuff. Of course, we'll show this slide again. Coming in for your regular eye exam, it's not just about the glasses that you may or may not get at the end. It's really about ensuring that you are seeing the world to the best of your ability. So we can, of course, track and follow macular degeneration, get you to the right places we need to be, but also we're looking out for dry eye. What stage are your cataracts at? Is there any glaucoma? In this person, there's a bleed in the center of the eye. The blood vessels aren't draining as they should. Is this because of a vascular issue? Is this because of some sort of blood cancer? Is there something blocking the outflow there? Is the nerve swollen? Lots of severe things, and then also run-of-the-mill things. So routine exams should be about every 2 years, and at Ashburn Eye Care will enroll you when you're due back, and sometimes that's shorter and sometimes that's longer depending on what we see. And like I said there, ensuring that your glasses, your contact lenses, your ortho-K, that they're up to date. So we have online booking. If you're getting off the end of this webinar and thinking, shit, I need an eye exam, you can go to our website and book an eye exam. And there's a range of types of appointments there that can be done to maintain your eye health. So this being the third webinar, I know that I can't switch over to have a live Q&A, but if you do have any questions, feel free to write a comment on the video, if it's whether that's Facebook or on YouTube or Spotify. Leave a question, leave a query. Otherwise, you can send us an email at info@asheye.co.nz. And like I said, you can book online, and we're open Monday to Friday, 8:30 to 5 p.m. Thanks very much, and we'll catch you next time on the next webinar.